Hmm. Welcome. Okay, now. share. Greetings, everybody. Zanab. How are you doing, Zanab?
I'm fine, thank you, sir. How are you?
Good. You haven't been around. You haven't been around. Do you have a camera?
Yes, sir. I was on vacation. I do, sir.
Okay. Well, if you want to meet some neurosurgeons, it's good for them to look at your face because you just don't want to be another person. You want to be a person. It's a great way to make connections.
I was on vacation, sir.
Oh, okay.
Yes, sir.
Very good. Okay, welcome.
Thank you so much, sir. I'm
Okay.
glad to be here.
Good, good, good. You want to meet some people, and Jen, you don't have to ask questions because a lot of it probably you don't understand. I don't either, but you get an idea, and you hear, you keep hearing stuff, and it kind
Yes,
of
sir.
sticks with you. So I'll be back.
Yes, sir. Okay, sir.
Welcome, Mohammed.
Hi, John. How are you doing?
Good. How are you?
All is good.
Is your camera working?
Yes, it is.
There you go.
Yes.
Different
How are you
background
doing?
this time.
Yeah, it's a picture I took in Chinese city in 2018, I think.
Well, it's beautiful. And you
Yeah.
know, think of getting backgrounds that enhance your reputation. I mean, who you are. You know what I mean?
Well,
Like-
actually, I was thinking which background should I put, but actually, I prefer nature than just putting our hospital logo or something like that. So
Yeah. Well, you can do what you want. You can make a pretty background with the banner of
yeah, especially I'm not
your
going to
hospital.
speak.
And I
Yeah,
particularly
especially I'm not
like the
going to
neurosurgical banner with this
speak.
webcast, but you're certainly welcome to post whatever banner you want on your background.
Thank you.
So-
But today I'm not going to speak. I'm just here to listen. So that's why I bought this.
Yeah,
background.
that's fine. That's fine. Most people just use it for, beauty. I think it can be exploited. I mean, you can use it to make it look nice. But, you can do it if you want. Anyways, we start in about 20 minutes. So if you have some work to do, I'm just going to do a little promotion, okay?
Okay. I changed my virtual background. I hope you like it.
Oh, yeah. Well, I like them both. Like, you can have a bunch.
I'm just
Whatever
kidding.
you want.
I'm just kidding.
Well, you could center that. You can make it so you can see the head. You know what I mean? You can edit that picture. Because, it could look better if you could see the surgeon. Do you know what I mean? I can't hear you, Mohammed. I don't know why. Your microphone looks like it's on, but I don't hear you.
Okay, now it's okay?
Yeah, it's fine. Fine.
Okay, it seems my connection is not.
Well, just play with it. I'll be back.
Okay, John, sorry, I just turned off my VPN because VPN makes the internet connection more slow.
Wow, thank you. Oh, oh.
Welcome, Sylvia. Welcome, Sylvia. Are you there?
Good morning, how are you?
Good. How are you?
Fine, thank you.
Are you at the
What do I
hospital?
do today?
Yeah, are you at the hospital?
Yes, yes,
Oh, okay. Okay, we start in about 10 minutes.
okay.
Okay, welcome. Wan Lee, how you doing?
Hi, yeah, it's me. Yeah, good. Yeah,
How you been?
good. Yeah, yeah.
You've been busy?
Actually, not so busy. You know, there's still another wave of the outbreak of the COVID-19.
Yeah, I heard, I just read that yesterday.
So many hospital here in Beijing, you know, kind of not closed, but there's
Lockdown, right?
Yeah.
Not total lockdown.
Yeah,
Not-
because
not-
we the people still worry about
Oh,
the
man,
infection. So
I thought we were through that.
yeah. Anyway, okay.
Here is kind of like a memory almost,
Yeah, I know. Yeah, everything
Yeah.
back to normal.
but it may come back here too. Who knows? Who knows?
Okay, never. But today, you know, tonight there will be the opening ceremony of the World Cup, the soccer.
Oh, yeah, you like soccer?
It's popular here in China, although
Oh,
we don't have a good team, you know.
Well,
But-
get some Europeans. Bring some Europeans, bring some South Americans.
Yeah, yeah.
The Sylvia's territory from Venezuela and Chile.
There will be in Qatar, right? Yeah.
The World Cup's in Japan?
No, Qatar.
Qatar. Well, you know, they're
Actually-
having a big problem. Oh, Ben Zoo's waiting? Okay, I'm sorry about that, Ben.
I'm not sure. Yeah, being
而且要跑到庞化南去，省经理层不是想过去普通讲话。
Okay. Ben, I'm trying to get you in here.
我们过去了，我们两个人告诉。
There you go. You're coming in now.
and we have the Chinese speaker, Dr. Hong Hao.
我们得风表情。
I'm just online.
Hello, John.
Hey, Ben, how you doing?
Hi, fine.
Okay, so we still waiting. Waiting
这哪能进别的国际？
Dr. Hong is here. Hi, Dr. Hong.
Yeah, hi. Nice to meet you.
I'm Dr. Ben. Nice to meet you.
虽然这个大
Okay, Ben's here. Juan Lee's here. Okay, we start in 2 minutes.
因为医学还是老外发达。
Somebody has a TV
Hi,
on.
yeah, it's me.
哎
Yeah.
袁丽，我在问你，
我
今天主要靠你了。
没关系，Yeah, that's okay. Yeah.
啊，
也没问题，
OK
我在家嘛。
好
OK
好好，
侬何里地到有你什么职能？
It's okay.
阿拉
Okay, I'm just gonna, yeah, there you go. Someone had a TV on or something. So, okay, Mohammed, in about 1 minute, Mohammed, you ready?
Sorry, John, I'm not involved in this conference.
Oh, I didn't know that. I didn't
Yeah.
know that. Okay. Oh, Charlie, let me see what Charlie's at.
Actually, I would like to announce that today is the Professor Ben Shu birthday.
Oh, good.
Wow, really?
Yes.
Wow, congratulations. Oh, birthday. Happy birthday. So where is Charles Teo, Professor Teo here?
Oh, I'm trying to get him now.
Maybe he,
Yeah, hold on.
there should be around 10 p.m. in Australia, I think.
Yeah, he knows about it. He knows about it.
Okay.
I should have checked with him recently. We just had a conference yesterday with him.
Oh, really?
Yeah, and from from Sam O'Morsi. Here, let me try Facebook. Oh, okay. Oh, I'm sorry about that. Okay. Okay. Yeah, Charlie's here. I just didn't see him in the panel. What do I do? Okay, there we go.
Oh, yeah, he's
He's here.
yeah. Okay. Wonderful. Now we can start, I think.
Ahmad's here from Afghanistan.
Thanks for promoting me, John.
Yeah, Charlie, thank you. I'm sorry, make you wait there. Cool your heels.
Yeah, exactly. I'm sorry about that. Hopefully, can you hear me now?
Yeah, that's good. And you know the parties, you know Ben, right, Ben? Ben, you there?
In his birthday party.
Oh, he's at his birthday party?
I'm not sure. I just I guess.
Okay, do you want me to introduce Ben or you, Wan Lee?
Yeah, I think I can do it. Yeah, and maybe
Okay.
Wayne will introduce our Chinese speaker.
Okay.
later.
Okay, we'll do that. Wan Lee and okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We are hosting the Chinese Neurosurgical Journal Webcast. We've done these for a while, and we're honored to have the presence of infamous Charlie Teo. And I'll let Wan Lee give a proper neurosurgery introduction of Charlie. Welcome, Wan, and Wan Lee is a neurosurgeon from Beijing. And welcome, Wan Lee.
Hi, thank you, John. Hello, good morning, good evening, good night, everyone, all around the world. And this is the 15th webinar of our Chinese Surgical Journal. It's English journal focused on the neurosurgical paper, not only in China, but all around the world. So today we have two speakers. Let me introduce the first speaker, Professor Charles Teo, and he's the professor and it's a world famous neurosurgeon, and now he's worked in the Center of Minimally Invasive Neurosurgery, Sydney, Australia. And Teo is a long time good friend of many Chinese neurosurgeons, but actually not only Chinese, but all around the world. So he had visited China many times and gave us some live surgery. I remember you did a wonderful surgery, endoscopy surgery for brainstem cavernous angioma, something like that. Some more difficult case. Yeah, actually today he will talk about the designing strategy for complex brain tumors for us. Okay, thank you, Professor Teo.
Thank you very much, John. Thank you very much, Wan Lee. That's a lovely introduction. And it is good to be talking to my Chinese colleagues. I have many friends over there. I've, as you said, visited many Chinese cities on many occasions. And every time I go there, I enjoy it very much and enjoy the hospitality. So now my job is to share my screen. Let's hope this works. Okay, I'm just going to get rid of that. Get rid of that. And John, if you could just confirm that you can see my screen.
Yeah, perfect, perfect.
Look, Wan Lee's right. I talk a lot about keyhole approaches to many different tumours. And I've really been taken by the tentorial approaches to the supratentorial area and the infratentorial area. And I wanted to share with you some of my pearls and precautions of this approach. When used properly and in the right indications, it can really minimise collateral damage, minimise approach damage, because you are operating along natural planes and not having to breach any neurovascular bundles. So we all know of Roton's work in identifying and documenting all the many different approaches to the middle of the brain. But if you don't mind, I'd like to concentrate on these tentorial approaches: the occipital transtentorial approach, the posterior transventricular approach, the interhemispheric approach, and the infratentorial supracerebral approach to the two different areas of the brain. Let's talk about the supratentorial approaches for posterior third ventricular tumours, pineal area tumours. This was first described by Dandy, and then it was modified by Poppin, and finally modification by Jamison, who was an Australian neurosurgeon. It's a modified interhemispheric suboccipital retrocallosal approach. In other words, we don't go through the corpus callosum, we go behind the corpus callosum and either underneath the occipital lobe or interhemispheric. You can then go through the tentorium, you can go through the closed corpus callosum if you want to extend this approach, but the initial approach is a retrocallosal approach. What's good about this is that the veins are first, so there's early identification of the veins and hopefully their preservation. But the worst thing about it, of course, is that the tumour is last. The corridor is narrow, but you get good CSF drainage. And just remember, many of the articles written on this approach describe damage to the occipital lobe with retraction. So the whole point of this now with minimally invasive keyhole approaches is to not retract the occipital lobe and just to use these natural corridors to get access to this deep area. The infratentorial approach is a supracerebellar approach. It was first described by Krauss in the 1920s. It was popularized by Yazigul in the sitting position. It requires very good neuroanesthesia in the sitting position. But of course, we've now modified that so that lots of people, many people in fact, don't use the sitting position anymore. The worst thing about the sitting position, of course, is it presents a anesthetic challenge because there is risk of air embolism. There's a definite risk of quadriparesis and surgeon fatigue because the surgeon is holding his arms up in a very non-ergonomic type position. But it is very good for CSF drainage and brain conditions. So I'm going to talk about the occipital transtentorial approach, the supracerebellar infratentorial approach, the suboccipital transtentorial approach, and the interhemispheric transcallosal approach. Well, these are all approaches in and around the tentorium. Okay, first, the occipital transtentorial approach. Again, first described by Poppin and then modified by Jamison. The original description by Poppin was to go through the corpus callosum, but Poppin modified that to go behind the corpus callosum and between the two hemispheres. So you do have the ability to go through the corpus callosum if the lesion extends anteriorly, but the recommendation is to initially do a retrosplenial approach. These are the indications of the occipital transtentorial approach: pineal region tumours, superior vermis problems, problems with the pulvina, tectal plate, posterior third ventricle, And how do you choose this approach? Well, it's all about the long axis of the lesion pointing above the tent. If I could just give you some examples of how we would use an interhemispheric supratentorial approach, retrocallosal behind the corpus callosum through the tent to this lesion, interhemispheric. Why do we pick this approach? Just remember the 2-point rule. The 2-point rule says that you try and find the long axis of the tumor. You place a point on the most the deepest and most, risky part of the tumor, a point on the most superficial part of the tumor, join the 2 dots, extend that line to the surface, and that is your approach. Of course, if the tumor was in this direction, it'd be an infratentorial approach, but because the long axis is in this direction, we have chosen a supratentorial, transtentorial approach to this lesion with the complete resection. Here's another one, tectal glioma. Okay, now some people say, well, this isn't really a tumor with a long axis. It's almost like it's a perfect sphere, it's spherical. And it is true, but if the lesion extends into the 4th ventricle, then a infratentorial approach can't get you around this corner. You just can't get around this corner. So the more superior the approach, the more chance of getting into the 4th ventricle. So the SCID approach, supracerebellar infratentorial, does not get you around this corner into the 4th ventricle. And that's why we choose instead a supratentorial approach, which gives you a better chance of looking down into the 4th ventricle. We're just going to show a video now. Hopefully, again, John, if you can give me some feedback, is this video playing? Just
let's check it out here. It appears to be loading.
Can you see it?
Yes, it's fine. It's playing fine.
Oh, great. Okay. So this is a supratentorial, interhemispheric, transtentorial approach. So we're on the right side. We're retracting the occipital lobe. This is the free edge of the tent right here. This is the opaque arachnoid. This is the corpus callosum. So we're behind the corpus callosum. This is the splenium of the corpus callosum. We're going to open these CSF spaces to give us good CSF egress and good conditions. Once we get good conditions, we can then identify the anatomy and target the transtentorial approach. Okay, so these arachnoid membranes are always opaque. You have to be very careful as you go through these arachnoid membranes because the blue behind them isn't always CSF space. The blue behind these opaque membranes can sometimes be a large vein. So you've got to presume that there are large veins here. Open up these, you see the CSF coming out, you get good conditions. And once you get good conditions and the occipital lobe falls away, you'll see the gross anatomy of the falcotentorial area, and you'll see where to open the tent. Why is it important to know where to open the tent? Well, obviously, because you don't want to damage the vein of Galen, which will be entering the falcotentorial region to become the straight sinus. So what we do now is we zoom out a little bit. You can see that this is a falx, this is a tent. We're going to go through the tent at least 1 centimetre away from the midline so that we don't breach the straight sinus. The straight sinus is here. We're going to open the tent here at least 5 to 10 millimetres away from the midline. You'll always get into some venous lakes here. We're going to coagulate the venous lakes, and then we're going to open the tent widely. You can open it as long as you like. Again, as long as you are a safe distance away from the midline. Notice I just had a look then to make sure I'm nowhere near the vein of Galen. So we've now done the interhemispheric transtentorial approach, and we can open that tentorial incision as long as we like. And now we're into tumor into the posterior fossa here. This is a tectal glioma. You can see it's got the typical appearance of a low-grade astrocytoma. And you can see that we've really opened the tent widely so that there's no impediment or no hurdle to our approach to this tumor. The other thing you have to take note is that this gives you beautiful access to the ipsilateral side, not such good access to the contralateral side. And hence the importance of the endoscope in this operation to make sure that you indeed look to the other side and get a complete resection of this lesion. So we're going to get as much tumor out as we can using the microscope, and you can see things look pretty clean here. And now we're going to put the endoscope in and look with a 30-degree endoscope to the other side to make sure that we've got a complete resection. Notice there's no fixed retraction on the occipital lobe. The occipital lobe has simply fallen away because of CSF egress. Here's the falx, there's a straight sinus, here's a hole in the tent, there's the vein of Galen, and we're looking over to the other side now, and you can see we've left some tumor behind that was impossible to see with a microscope, but clearly seen now with the endoscope, the 30-degree endoscope looking to the other side. So we can achieve a complete resection now, and we use the 30-degree scope to look forwards, backwards, ipsilateral, contralateral, and again, to ensure that we've got a complete resection of this tectal glioma. And pre-op and post-op. Look at the long axis on this one, just above the tent. You could have taken this through a skid approach, but we chose a supratentorial approach. And again, complete resection because we're operating in the long axis of the tumor. Disconjugate eye movement is a risk of the operation. In fact, it's a very high risk. About 50% of patients will experience at least a few days, if not weeks, of disconjugate eye movement. In the majority of cases, it improves. In a few cases, it's permanent. And of course, it's all because of the manipulation and bruising of the tectal plate. Here's another pineocytoma, complete resection, 1 day after surgery. And we can see how the operation has evolved with time. This is the way I was taught to do it, with quite a large curvilinear flap incision. I don't like that. I've now modified it over the years to make it just a straight incision in the midline so that we can go both sides if we have to, but a nice straight midline incision. That's the incision I make. I put the patient in the neutral position. So no flexion, no extension, purely neutral. And again, a straight midline incision. Some pearls and precautions. Don't retract the occipital lobe. You don't have to when you get good CSF egress. You can coagulate and sacrifice the occipital bridging vein with impunity. There's no problem in coagulating and sacrificing the occipital bridging vein. Go behind the spleen of the corpus callosum is better than going through it because then you don't run the risk of damaging the fornices. And beware the hidden apex. And what I mean by that is this. This is the incision of the tent right here. Well, the worst thing about incising the tent right there is that you don't see the apex. See, if you make your incision in the tent there, you're not going to see the apex of the posterior fossa, the top of the tent right there. So that's why you have to make sure you use the endoscope to look up into that apex to ensure that you get a complete resection of your lesion. And remember, the endoscope is a very valuable instrument. At the end of the case, position the patient's head with the operative side down in the immediate post-operative period to reduce the incidence of subdural hygroma or hematoma. You're basically using the weight of the brain to try and reduce space so that you don't get a subdural hygroma. And remember what I said, you've got to warn patients, at least half of them may get some disconjugate eye movement. Thankfully, in most cases, only temporary. Okay, now let's talk about the supracerebellar infratentorial approach. This was first described probably by Krauss, but it's very difficult to know who actually first described it. The original description was actually a midline bilateral posterior fossa craniotomy We've now modified that to be a paramedian incision and a paramedian craniotomy. It's great for all those lesions around the falcotentorial area, pineal gland, superior vermis, posterior third ventricle, etc., and you pick it again by the long axis of the lesion. Here's a beautiful case. Again, you can see this tumor, posterior third ventricle. We look at the long axis. The long axis takes us below the tent. So we're going to go below the tent. Now, if you look at the midline sagittal cut, it looks like you're going to have to retract or damage all this bit of brain here, but that's not the case. It's not the case because you've got to think of it like standing behind a camel. If you're standing behind this camel and you want to look at its head, then if you are in the midline, you're not going to see the head because of the hump of the camel. However, if you move to the side and do a paramedian approach, then you'll be able to see the head of the camel. So the analogy is that if you stand behind, in other words, a midline approach, the superior vermis is going to get in your way of the falcotentorial pineal region. If, however, you do a paramedian approach, then you'll be able to see the head or the pineal region without retracting or damaging the superior vermis. Here's a falcotentorial meningioma right at the junction of the tent, the falx, inferior sagittal sinus, straight sinus, vein of Galen. This is a very dangerous lesion right there at the falcotentorial junction. This is a video. This is how I used to position the patients. So it's a paramedian approach, about 2 finger breadths away from the midline. We sacrifice all the bridging veins from the superior surface of the cerebellum to the tent. They can be sacrificed without any problems to get access to that area. Once we get to that area, we see the very same opaque arachnoid that can really obscure bridging veins. So you have to be very careful when you go through that arachnoid. And here we are now at this meningioma at the apex of the tent in the posterior fossa. We use standard microsurgical technique to remove it. And once we remove what we think is the entirety of the tumor, we then put the endoscope in again and we have a look. So this is underneath the tent. These are the venous pools. This is the superior surface of the cerebellum. This is a free edge of the tent. And here's the tumor right at the apex of the tent. You can see where we've removed the majority of the tumor, but you can also see that we've left some behind here. Impossible and invisible to see with the microscope, but clearly seen with the endoscope. The endoscope's a 30-degree endoscope looking superiorly, and it's obvious that we've left tumor behind here in the apex. This is very risky surgery because you know the vein of Galen is going to be attached to the supro-anterior surface of this meningioma, and you can't just grab it and pull it. You really got to dissect this off the bridging veins that surround this tumor. So it was very tough. This sucker wasn't really succeeding in sucking out the tumor, so we ended up having to use a co-blator, which, as you know, has a sort of quasi-type cavitron at the end, and we are now sort of melting the tumor and sucking it out using this malleable, disposable device called the co-blator. And you can see that I'm not creating too much traction because I'm really worried that the bridging veins are above this, and it'd be wrong to pull on that. And we achieve a near complete resection. Here's the pre-op and the post-op showing no obvious residual tumor, although this might be some here. We've been following this patient for many years now. That hasn't grown, so it's probably a Simpson grade 2 removal. It's also the approach that I've adopted to the pineal cyst for pineal cysts. This really is opening a Pandora's box. You all know how common pineal cysts are, and most textbooks tell you that pineal cysts can't cause symptoms and should never be operated on. I challenge that dogma, as you know. many years ago. I've been operating on pineal cysts now for about 20, 30 years. We published our first series in 2015, and we've published our next series just last year, showing very, very high success rates in resolving the symptoms of these people with symptomatic pineal cysts. Here's our first publication in 2015. This is our next publication in 2021, showing a very, very good results with these patients. A total of 97 patients. Almost half the patients had headache that were positional, with 82% being bilateral. Surgery resulted in 89% of patients with clinical improvement of their headaches. So in a well-selected group of patients, you can indeed get very happy and successful patients. They all had endoscopic assisted removal of the cyst. We left some of the pineal gland in most patients. So it's a pineal gland sparing operation. And of course, we chose the approach on the long axis of the tumor. The long axis took us above the tent, then we do occipital transtentorial retrosplenial. And if the long axis took us below the tent, then we do a skid approach, a supracerebellar infratentorial approach. We have changed our positioning of the patient. It used to be prone, and then it was lateral decubitus, and now we just do them supine. Here's the midline, 2 finger breaths across away from the midline, straight incision. This is the transverse sinus. And of course, you've got to make sure that you see the transverse sinus. This is how we used to position them. This is how we position them now. And again, 2 finger breaths away from the midline. Burr hole right at the inferior surface of the sinus, small craniotomy. Oh, I can't find that video. Don't worry. I can show you another video. Oh, hang on. That might be a video there. Let me just see that. Oh, I can play some. I don't worry. I'll play some videos for you later if we have time. And the data is very, very good. Again, almost all patients had resolution of their headaches. The imaging post-op is very telling in that patients will get resolution of their aqueduct stenosis. And the cosmetic result is very good. The incisions behind the hairline. Okay, let's talk about the suboccipital transtentorial approach. This is an infratentorial supracerebral approach to mesioccipital and temporal lesions. It's excellent when significant intracranial hypertension in the supratentorial compartment. And the major advantage, of course, is preservation of all those lateral structures. This is what we're talking about. Okay, when lesions are lateral to the atrium and occipital horn, they've invariably damaged the optic tract already, and therefore a lateral approach is very reasonable for lesions that have already destroyed the optic radiation. If a lesion is medial to the occipital horn, then you by nature have preservation of the optic radiation, and therefore a lateral approach is not appropriate. In that situation, we do a tentorial approach. In other words, it's a skid approach going through the tent. So it's an infratentorial, supracerebellar, transtentorial approach to these supratentorial lesions. Remember what's lateral to the occipital horn. You've got all these fibers of optic radiation and these along tracks, IFOF. There is a safe window, but that window is very difficult to find. It's a very small window. So if you are going to come lateral, you have to come very low, below the optic radiation, and of course, not damage IFOF. So again, skid approach, large opening of the tent, so that doesn't get in your way. Sacrifice these bridging veins if you want to, but a large opening of the tent. Here's an example. This is an airline pilot who had preservation of his entire visual field. He had no visual field defect, and you can see why, because the lesion is medial to the occipital horn, and you can see the optic radiation has been stretched around the outside of this lesion. Any lateral approach would have given him a visual field defect. So this is how we're going to do it. We're going to come under the tent, open the tent from here to here to give us really good access. And so it's a infratentorial, supracerebellar, transtentorial approach to this supratentorial lesion. And again, there's the approach, opening of the tent, complete resection, and preservation of the lateral structures. There's another small lesion. Again, you can see here, this is the approach. That's the incision. Excuse me. Wide opening of the tent. There's another small one. And here's the approach. No fixed retraction on the patient's right side. We've identified the inferior surface, inferior border of the transverse sinus. The flap is against the transverse sinus. The cerebellum is pushed down but not held down. Anything that holds up the cerebellar surface, bridging veins, can be sacrificed with impunity. CSF comes out as soon as you start dissecting here, CSF starts coming out, but you get really good relaxation once you get into the cisterns here. Here's the free edge of the tent now. What we're going to do now is open the tent widely, so we're coagulating the tent. Remember, I told you it's full of venous lakes. You've got to coagulate those venous lakes, and you can open this tent as wide as you like so that there's no hurdles or no impediments or no obstruction to your view and manipulation of the supratentorial tumor. Take this incision all the way forward to the tentorial edge, and there we have it. So wide opening of the tent, relaxation of the cerebellum, sacrificing all the bridging veins, and then going into this part of the brain right here to get this tumor out. And large tumors can be done, small tumors can be done, meningiomas can be done. So there's a meningioma. We don't want to come lateral. Coming interhemispheric is possible, but again, it extends very lateral. So an interhemispheric approach would have been very difficult. A lateral approach would have been very destructive to the optic radiation or IFOF. So we're going to go supracerebellar, we're going to open this tent really widely from way back here somewhere so that we can get good access to the entirety of this tumor. And there's the wide opening of the tent. And there's the post-op scan showing a complete resection. There's the opening of the tent. Look, all the way back there. The whole tent's been opened up. And none of the structures lateral have been affected. This is a T2 post-op picture. I just want to show you that there's no footprints. So the tumor's out. There's no damage to the brain. No damage to the brain here because very good relaxation. So have a look at that. There's the tumor. There's the occipital lobe, no damage to it. There's the superior surface of the cerebellum, no damage to that. That's just checking her visual fields with normal visual fields. Finally, let's talk about the interhemispheric transcallosal approach for falcotentorial tumors or tumors in the posterior third ventricle. You select this approach for huge lesions without a long axis. So in other words, if there's no long axis and they're very large, this is probably the shortest route to the falcotentorial area. The craniotomy has to be a long craniotomy because you've got to assume that there is a major bridging vein in that craniotomy. So if the large bridging vein is right in the middle, then you've got to make sure that your craniotomy in front of or behind that large bridging vein is big enough. The conditions are often very tight here because you don't get down to CSF until not early. So sometimes you need to tap the ventricle to get into these lesions. And of course, beware all these deep bridging veins. Here's your perfect example. You can see that to get into CSF here, it's going to take a long time. We actually tap the ventricle in this case to give us good conditions. And again, here's the approach. It's interhemispheric. It's interhemispheric because this is purely spherical. We could have done this through a skid approach. We could have done it through a supratentorial approach, but you can see that the superior approach is the shortest route to this lesion. There's positioning. It's neutral positioning, slight flexion, a long incision. And remember, you make this long incision because you've got to assume that there's a bridging vein right there. If there's a bridging vein right there, then the craniotomy above it or below it has to be big enough to give you access. If there's no bridging veins, and of course, you know, you've done a craniotomy bigger than necessary, but you've just got to assume that there's going to be bridging veins that you want to preserve. So it's a long incision, it's a long, thin craniotomy, and that gives you good access to these lesions. There's the pre-op, and there's the post-op showing a complete resection of this lesion and a very good outcome, no neurological deficits. So I'd like to conclude by saying that the keyhole tentorial approaches provide excellent access to deep-seated midline and paramedian lesions both above and below the tent. Keyhole tentorial approaches require comprehensive preoperative planning, application of the two-point rule, and generous use of endoscopy. If I could just underscore a few of those points. Okay, the first thing is that you must look at your x-rays in all three planes, axial, coronal, and sagittal, and find the long axis. Most lesions aren't perfectly spherical. Most lesions have a long axis, and it's the identification of the long axis on those three sequences, axial, coronal, sagittal. It's no good just looking at one sequence. You've got to look at all three sequences, pick the long axis, and then draw a line from the deepest part to the most superficial part. Where that comes to the surface is where you're going to do your access, either above or below the tent. Okay, so it's very, very important for that preoperative planning, two-point rule, long axis rule, either above or below the tent. Once you choose the approach, there are several, again, very, very important principles. The first principle is you do not need fixed brain retraction. Fixed brain retraction has been shown in the literature to cause damage to the brain that's being retracted. That is totally unnecessary if you position your patient well and you allow CSF to be sucked out to give you good conditions. You do not need to use fixed retractors. The third thing, and the most important thing, is that all those deep veins in and around the falcotentorial area are extremely important to preserve. Now, that's easier said than done because they're incredibly fragile. They sometimes stuck to the lesions, and they sometimes can't be seen until the lesion has been removed. Just remember this. The anatomy is really important. Remember the two basal veins of Rosenthal coming around the brainstem, joining the confluence of veins with the vein of Galen to form the straight sinus. The straight sinus is also formed by the inferior sagittal sinus joining that same confluence. There's only a few veins that can be sacrificed. There is a bridging vein that goes from the occipital lobe to the basal vein of Rosenthal, or sometimes at the junction of the basal vein of Rosenthal to the vein of Galen. That bridging vein can be sacrificed, and it's a whole lot better to sacrifice it than to tear it and result in a hole in those veins. So just remember that. Preserve the basal veins of Rosenthal, the internal cerebral veins, the vein of Galen, the straight sinus. You can sacrifice all the other veins. Even the precentral vein, You want to try and preserve it if you can, but it can be sacrificed sometimes as well if you have to. But you can't sacrifice those other large bridging veins in that area. And finally, positioning the patient is probably more important here than anything else. You do not need to use the sitting position anymore. It's tiresome. The arms are up the whole time. It causes surgeon fatigue. It increases the risk of air embolism. It creates new risks like quadriparesis. It was essential in the days before good anesthesia, good lighting, and good instrumentation. Now that we have all those things to give us better conditions, you don't need to use the sitting position anymore. It's cumbersome. It's time consuming. You need anesthetic expertise. And again, it increases the risk of the operation. Now we can do it just through a simple supine position, head turned to the confluential side, paramedian incision for the infratentorial approach. And if you're going to do a supratentorial approach, prone position, straight head, no turning, no flexion, no extension of the neck. It's a very neutral prone position. Thank you very much.
Thank you, Professor Teo. Thank you for your wonderful lecture. And so, are there any questions about Professor Teo's talk? No. There is one.
Yes, please.
Go ahead, Mohammed.
Thank you, Professor Charles Leo. Good evening. Actually, I'm more than pleasant to talk to you virtually tonight. Actually, I got to know you a few years ago when I was in medical school searching the web for the advancement in neurosurgery. I saw you talking about keyhole neurosurgery, which was very fascinating to me that time. Actually, since then, I become one of your international fans, watching most of your interviews, including the recent ones on A Current Affair, Today, My Big Story, and so on. So regarding keyhole surgery, I was lucky enough to join Shanghai Huashan Hospital to follow Professor Shu Bin, my neurosurgery idol, who performed a successful 14 millimeter keyhole STMCA bypass in patient with moya last week. So actually, my question will be more seeking advice rather than a professional question. You had work on both public system and private system. You built a very big name, but you faced a lot of struggle in your career. So could you please share your advice with me and other young neurosurgeons about pros and cons of private and public systems and how to maintain your success as a neurosurgeon despite all the huge struggles you may face in your career? Sorry, I forgot to introduce myself. I'm Mohammed Hilmi, originally from Egypt. I'm a master's degree student now in Huashan Hospital, Fudan University. Thank you.
Mohammed, it's very kind of you to be so complimentary. It does make me feel a bit old that you have been following me since you're a medical student, but nevertheless, it has been a long career.
Sorry, I'm so young. I'm just starting my neurosurgery career.
Look, I can answer that. I mean, to give you a comprehensive answer to that question would take me hours. But let me just tell you some of the pros and cons of private and public. I think the public system works well because patients don't have to pay anything. It's your way of giving back to society. In Australia, at least, you don't get paid very well in the public system. And I just feel like it's paying back or giving back to society. The worst thing about the public system is that, unfortunately, certainly in Australia, there's no sense of reward of excellence. In fact, because the public system is so stretched and so limited in its resources, a good public hospital is an empty hospital. Any hospital that's full with lots of patients, of course, they go over budget and they get penalised for it. So that works against the surgeon, because if a surgeon is good and he wants to attract lots of patients, then of course the hospital doesn't like that. The good thing about the private system is that it rewards excellence. The better you are, the more patients you get. The more patients you get, the more the hospital likes you, the more money you make. So it's a very satisfying, rewarding system. The only bad thing about the private system is that, unfortunately, it is open to abuse. And once you start paying people for, in English we say it's eat what you kill. So once you start giving people reward for doing lots of patients, then sometimes they cut corners, sometimes they relax their surgical indications, and they might do operations based on financial reward rather than what's best for the patient. I have found that the good balance is to have an academic practice in a private institution. Private institution allows you more autonomy, allows you to reward excellence and to surround yourself with a team of people who are all like-minded. But if you have an academic practice, it means that you are surrounded by residents and fellows who are always questioning you and keeping you on your toes. It's very difficult to do the wrong thing by the patient when so many people are involved, like fellows and residents and other doctors keeping an eye on you. So I found that's a really good balance to have an academic setting in a private institution.
Okay, I believe Uday has a question. Or do you have a follow-up question, Mohammed?
Hello, good afternoon, sir. Good afternoon,
Go ahead.
sir. Yeah.
Hello.
Sir, I've been following your, I read your textbook also, the Principles of Keyhole Surgery, and attended your previous webinars in Seattle Science also 1 year back. And previously also you had mentioned to get more knowledge about connectonomics and functions of the brain. That was a very good webinar where you told about the salience network and the DMN network. So I wish to learn more. Are there any options where I can work under you, any observership or fellowship program for the keyhole approaches?
Yeah, absolutely. Look, I'm at a stage in my career now where I'm sort of trying to do more teaching. I've always been a frustrated teacher. I love it very much. I love teaching as much as I love operating. And your job is to get in touch with me and invite me to your hospital for 1 or 2 weeks where I can just come and immerse you in connectomics and keyhole approaches. And I'd love to do that. I don't charge any money for that. You can pay for my accommodation. You can feed me. And I can do some demonstration operations. I can teach. And that's the stage I am in my career where I really feel like it's my responsibility to spread the knowledge. And you're absolutely right. Connectomics has changed my entire approach to brain tumors. Not so much extraaxial lesion tumors, but certainly anything intraaxial. In glioma surgery now, I won't do surgery without a map of their networks, so that you can preserve not only the obvious networks, but preserve the more subtle, higher cognitive networks such as salience, DMN, and CN. So yeah, I would love to teach you all about it. There's a lot to learn.
Yes, sir.
You need to apply it to your practice. What you see now, you can't unsee. And I think it's our responsibility to give our patients the best outcome by incorporating connectomics into all brain surgery. Again, not so much for extraaxial lesions like meningiomas, but certainly for all intraaxial lesions.
So I can attend your place for and learn there if it's an option for you. I work in a like government setup. I can come and learn from you if you allow, sir.
Yeah, no. Again, my situation is different for all of those all those people listening. If you want to learn my techniques or if you want me to teach, unfortunately, I'm not operating one particular area now. I'm operating all around the world. So you could follow me around the world, but the best thing is to actually invite me to your institution to teach in your institution.
I worked with Mr. Tandon also at Aditya, where you visit, sir. I worked my observership also for some time there also. If you are coming there, I can. I'll like to learn from you there also.
Exactly, that'd be good. That'd be a good compromise.
Do you want to put your contact info, Charlie, in the chat?
Okay, sir.
Oh yeah, I'm very happy for anyone to have it. It's very simple. It's Charlie@neuroendoscopy.com. neuroendoscopy.info. Everyone can remember that. Charlie at neuroendoscopy.info.
Thank you,
That's
sir.
the best way to get.
I'll follow you, sir. Any other place also, I'll come and learn if when I get the time. So, thank you.
Well, it's my honor. It's my pleasure.
Thank you, sir.
We have one question, Charlie, from Tiao Jiang. I don't think anyone's asked that.
Yeah, that's about how do you think transcorridor approach to tumor? Actually, I also want to know. I mean, for the transcorridor approach.
Okay, so yeah. Let me talk about the transchoroidal approach. So remember, you've got to distinguish between a posterior third ventricular lesion and a pineal region lesion. They are two completely different animals. A posterior third ventricular lesion means that the major deep draining veins are posterior to the lesion. So therefore, the more anterior approaches are more appropriate. If it's a pineal lesion, then it's behind the bridging veins, and therefore a more posterior approach is appropriate. So if you're going to do a pineal region tumor, then a transchoroidal approach by definition is not the right approach. If it's a lesion in the posterior third ventricle, absolutely, sure. Interhemispheric, transcallosal, transventricular, transchoroidal, or suprachoroidal or infrachoroidal, above or below the choroid plexus to the third ventricle is very appropriate. And I can do, you know, Don, if you want me to give a talk on that, I've got another talk just on third ventricular lesions. Remember, this talk was on lesions in and around the tent. Now, third ventricular lesions are completely different. And, you know, that's where we start talking about interhemispheric, transcallosal, transventricular, transchoroidal approaches to the third ventricle.
Okay, thank you. Thank you so much. Yeah, it's very clear. Okay, so thank you again, Professor Teo. I wish you can, you know, visit China again, maybe very soon. Okay.
I'd like that very much. Thank you, Anli. Thank you.
Okay, Charlie, I'll write to you.
Sydney, right? So it's almost midnight, right?
Yes, it's 11:52.
And he spoke last night too.
Okay, thank you again. Thank you. See you
Pleasure.
next time. Okay. So now we move to the next speaker from China, Professor Hong Tao. He's from Beijing Xuanwu Hospital, also one of the largest neurosurgical center in China. And today he will introduce some clinical experience, also basic research for the AVM, the arteriovenous malformation. Yeah.
Hi, good morning and good evening, everyone. First, let me check. Is my screen is correctly shared?
Okay, yeah, very good. You can.
Okay. So now let me begin. So it will be it's a different topic. Although I'm also a neurosurgeon focused on the neurovascular diseases, and but today I'm going to talk about some genetic pathway advances in central nervous system AVMs and potential pharmaceutical therapy. So I'm Dr. Tao Hong from the Department of the Neurosurgery, Xuanwu Hospital, Beijing, China, also the National Center for Neurological Disorders. Well, today I'm going to talk about the central nervous system AVMs, because from the genetic mechanisms of the point of view, the brain and the spine and the extracranial AVMs are highly homologous. So they're the same thing, as details mentioned later. So, so the genetic pathways of the cerebral AVMs applies to the spinal AVMs and the extracranial AVMs very well. So our back to the history, our knowledge of the genetic backgrounds of the brain and spinal AVMs starts from the HHT. It's early in discovered in the early 20th century, and when now very clear that the HHT are caused by the germline mutations of the ENG, the ACVRL1, and the SMAAV4, and its ligands BMP9. So 4 genes. It's a germline mutation, and it's all focused on the TGF-beta signaling that plays an important role in angiogenesis and vascular remodeling, which means that the endothelial cell specification towards the arterial or venous phase. So the HHT is very clear now. The 4 genes, germline mutations, and also we have learned from the HHT the 2 hits theory. It means that the germline mutation itself cannot cause the AVM lesion. If we want to do make an animal model, we will add some VEGF, some or you have a germline mutation plus injury from the environment, or germline mutation plus the somatic mutations. So the 2 hits theory is also a very, very important lesson we learned from the HHT that also works later in sporadic AVMs. Then later, the genetic backgrounds of other familial AVMs are revealed, all caused by different germline mutations. For example, the CM-AVM and the NF1. So they are all germline mutation, but the genetic mechanism of the sporadic AVMs, which represents the majority of the brain and spinal AVMs, are unclear for a long time. People try to find the germline mutations, but fail. Now we know that from the pathological and genetic point of view, familial AVMs and sporadic AVMs are distinct lesions. Sporadic AVMs are not caused by germline mutations. So this is the way that we are generally approaching the sporadic AVMs for their genetic mechanisms. So the earliest paper is published in 2017, 4 years earlier, 4 years ago, on the American Journal of Human Genetics. In 7 of 10 extracranial AVMs, they have found the somatic, means that the nidus rather than the tissue around it, surrounded, have a mutation. It's the mutations are KRAS, and the mutations is named MAP2K1. It's RAS signaling, and the mutation is enriched in endothelial cells, and we're not presenting blood. It means that it's somatic mutation, not the germline, which they have mutations all around the cells of the whole body. So later, as we all know, that Ivan Radovic from the Toronto Western Hospital published in 2018 in New England Journal of Medicine. They have found that 60% of the somatic brain AVMs obtained KRAS somatic mutations, which is a very overwhelming finding. They have also enriched that mutation in endothelial cell. So it means that the AVM is probably a disease of the endothelial cell. And later, the paper published in JCI also revealed that the AVMs all around the body, intracranial, extracranial, are somatic mutations of the KRAS, BRAF, MAPK variants. So, and the mutation of the KRAS specifically activating the MAPK ERK pathway in endothelial cells rather than the mTOR. So very single pathway, and which cause the AVMs all around the human body, which is a very exciting finding, which indicates the pharmaceutical therapies. So later, our group has also reported that in 31 patients, very high prevalence of the KRAS BRAF somatic mutations, thanks to the panel signaling panel sequencing, which specifically target 422 tumor genes. So our average sequencing depth is more than 1,000, which could find mutations with very low variance frequencies. So we have revealed that 87% of the CNS AVMs harbor KRAS BRAF mutations, which is even higher than Dr. Radovic reported in New England Journal. And plus the BRAF gene was firstly reported in central nervous system AVMs. So why our findings have a higher prevalence, two reasons. One is a very deep sequencing using the panel sequencing. And second, we use a fresh tissue, which will avoid the false positive. So what's more, we recruited the spinal AVM samples for the first time and found that the spinal AVMs and brain AVMs shared mutations in KRAS and BRAF. So a causative role of the somatic activating mutations in KRAS and BRAF, the overwhelming majority of the brain and spinal AVMs. It means that this pathway supports the development of the targeted therapy with the RAS, RAF, MAPK pathway, maybe inhibitors, and without the necessity of tissue genetic diagnosis. So later, a very important question has raised that is this KRAS mutations a cause or an effect? So in this paper, Dr. Wave in Baylor used a mouse model which is a SLC01C1 mice, allows the brain endothelial specific recombination. And they have found that the KRAS is sufficient to cause the vascular malformation if they harbor a KRAS mutation. The brain AVMs will form. Later, Parker and the colleagues have used the AAVBL1 virus carrying the KRAS mutations to confirm that the KRAS is a cause with a higher efficiency. So with these animal models, we're studying the detailed molecular pathobiology of the AVM formation and the progressions. So we know the gene, we know the pathway, we have the mice as a tool, as a neurosurgeon struggling treating the brain and spinal AVMs every day. So we have some way, we have some hope to seeking the pharmaceutical therapy for AVMs, especially we have many candidate compounds. So actually, here now there are 4 potential directions for AVM pharmaceutical therapy development and research. First one is an anti-angiogenesis, which is a very quite old direction, because many people are trying that in early days. So because the plasma VEGF level in patients of brain AVMs is upregulated, and the expression of the VEGF as well as the VEGF receptor in brain AVM surgical samples were also significantly elevated. It's well-founded. So the VEGF inhibitor, the bevacizumab, was chosen. Last year, the proof of concept single-arm trial of the bevacizumab therapy for brain AVMs have recruited 2 patients with large, which is a special margin grade 4 and 5 brain AVMs. However, the AVM volume observed half year and the whole year after the treatment were not changed compared to the baseline. And also the rupture of the F1 AVM was reported. So this means that the VEGF inhibitor maybe is not a good way. So the second direction is the anti-inflammation. Because similar to the angiogenesis, the vital role of the inflammation in the progression of the brain AVMs has been recognized since the early pathological studies. So recent published single-cell athletes of the brain AVM also confirmed the contribution of the inflammation programs for brain AVM rupture. So they have tried the doxycycline, which shows anti-inflammation effect. So they recruited the 10 participants to receive doxycycline for 1 week prior to the brain AVM resection. And when they do the surgery, they resected the lesion, and they can measure that a trend of the MMP9 expression is reduced. And in 2007, the William Yang and the colleagues have recruited 12 brain AVM patients and treated with doxycycline up to 2 years, but their results may fail to show a trend towards the patient benefits. And also they have 1 patient ruptured during the treatment. So actually the angiogenesis and the anti-inflammation have been tried for more than 10 years, and which people don't think is a very promising direction for the brain AVM medication development. The third one is to enhance the vascular integrity, because brain AVMs in both human and mouse model featured with abnormal vessel lacking neural cells. Means that the vascular smooth cells and the pericytes means that impairing vascular integrities. And thus repairing the vascular neural cell has been considered as a potential treatment strategy in recent years. And this hypothesis was mainly inspired and encouraged by the efficacy of the thalidomide for patients with HHT. Thalidomide can rescue the pericyte coverage of the HHT by enhancing expression of the PDGF-beta of the endothelial cell. You can see that above they are the HHT samples. You can see that very thin layer of the pericyte around the vessel lumen. But after the endothelial treatment, you can see that very thick pericytes surrounding that, which make the vessel wall more strengthened, and it may indicate that the less chance of the rupture and the bleeding. So we, in our recent work, we have tried the thalidomide for the brain and spinal AVM patients. And in our benchmark work, in our lab work, we have we can see that the thalidomide restore the PDGF-beta expression in sporadic AVMs and stimulates the neural cell migration. And so we have done a pilot study. We can see that from the sporadic brain and spinal AVM patients who are refractory to surgical treatment, and we can see in some patients they have very amazing results. For example, for this perivertebral AVMs, the lesion after the thalidomide treatment is nearly gone. And this is a very small brain AVMs after the thalidomide treatment, almost obliterated. So it's still very preliminary data, and we're still following that. So from the skin samples of the COP syndrome patients, which means that in spinal and the skins, they have both the same AVM lesions. So we can do the biopsy of the skin to reflect the lesion change of the intracranial lesions. So we can see that the thalidomide increase the neural cell coverage of the AVMs in humans. However, the thalidomide is not the ideal medication for sporadic AVMs for its frequency toxicity, such as a peripheral neuropathy. But it gives us very nice evidence. So we have animal models, we can follow this pathway, we can see, we can discover the mechanism of how the thalidomide is treating the AVM lesion, and based on that, we can find more target, and maybe we can find more ideal medications following this pathway. So the fourth direction is the RAS-RAF-ERK pathway inhibitors. So they are mainly the anti-neoplastic drugs. And in Dr. With animal model work, it reported that trametinib, the MAP2K1 inhibitor, could restrict AVM occurrence or growth in animal models. Until now, there are 4 patients with extracranial AVMs received the trametinib treatment, indicated that the size and the blood flow of AVM lesions in patients receiving trametinib were shrink. So there was till now, there was no clinical investigated genetic in patients with brain or spinal AVMs in the literature, only the extracranial AVMs. But I know that there are some groups are trying to doing the very pilot clinical trial to investigate that. Yes, in the report of the patient with the COP syndrome, we noticed that although the extradural AVM have been shrunk after genetic treatment, the blood flow in the lesion size of the intradural AVMs of the spinal cord were not changed. And in addition, considering the longer survival of the patient with AVM than those with malignant tumors, the side effect of the anti-neoplastic drugs should not be neglected. So according to the pharmaceutical treatment of the AVM, it's still on the way and definitely a large opportunity for investigators in the future. So last but not the least, let's move to the cavernous malformation, another form of the vascular malformations in central nervous system. So very similar stories. The familial cavernous malformation represents the 15% of the whole CM, and the sporadic CM represents the majority of them. And the familial cavernous malformations, the pathogenic genesis are very clear. The CCM1 to 3 germline mutations, but the sporadic CM was not clear. So last year we have found we have also found that the somatic MAP 3K3 and PRK3CA mutations in sporadic cerebral and spinal cavernous malformations. Very similar stories. Somatic common tumor genes in low flow vascular malformations. So in 81 sporadic CM patient samples, the MAP3K3 and PRK3CA mutations were detected in 90% of the cerebral spinal CM lesions. What's more, we have found that the patients have different mutations have significantly different occurrence of the overt hemorrhage events. So according to the genetic mechanism, of the cavernous malformations, besides the familial CCM1 to 3 germline mutations, we have found the new PRK3CA and MAP3K3 pathways, which in all will form the whole pathway, the story of how the genetic mutations cause the cavernous malformation. So we have also made the animal model, and we can see that the MAP3K3 itself can cause cavernous malformation lesions in mice brains. So according to this, I thank you, Dr. Yuanli Zhao, for inviting me to this webinar and share our work on our thoughts of the genetic pathway of the vascular malformations in central nervous system. Thank you again.
Thank you, Dr. Hong. Yeah, you give us a lot of information about the genetic pathway for the arteriovenous malformation. And are there any questions here? Actually, I want to know, as we talked before, is there any possible for the potential medical treatment? So, like some antibody, like you mentioned the VEGF or the. Are there any clinical trial? I'm not sure.
Yeah, till now, I think there are only some very preliminary trials. We call it trials, or it's just one or two cases. They have case reports, and till now, as I know, someone is trying the trinitinib, which is MAP 2K1 inhibitors, and they are trying. They are also trying some BRAF inhibitors, but till now there's no solid data showing that there is one compound that really effective to the majority of the brain and spinal AVMs. Yeah, but it's definitely on the way, and we definitely are confident that we will find something in the future.
Okay. Yeah.
Okay, we have a quick one. We have a question from Bikram Chakra. Do you see it?
Yeah, but I think there's similar question as I asked.
Okay.
Are there any medication for patients not waiting for surgery?
Yes.
If
yes. Till now, there's not a single one which can be used at once, but in the future.
Actually, for me, it's for some large diffuse AVM cannot surgery. For me, sometimes I just suggest they try the Lipitor, the statin. Maybe I'm not sure. But yeah, just better than nothing. I don't know.
Yeah. For some very large AVMs, which the surgical treatment is not available.
I'd like to welcome Takashi Khan, a Japanese neurosurgeon. Do you have any comments, Takashi? Are you there?
Yeah, thank you so much, but I am outside now, so.
Oh, okay, it's a bad time, okay.
Yeah, very informative lecture, thank you. So I will attend in the future, thank you very much.
Bad time for a question.
Okay. Yeah, are there any other questions?
Yeah, I don't see, let me look again now, we just got a message here, hold on. Oh, okay. Bikram is from Kathmandu, Nepal, the gentleman that just asked that last question.
Okay, so I'm not sure if Bing Xu finished.
No, I don't see Ben. I think he may have stepped away.
No, oh, yeah, so maybe we can see.
Yeah.
Yeah.
But I'd like to say hi to Sylvia Salva from Venezuela. Are you there, Sylvia? And Hani Balanos from Latin America, from Nicaragua. You can introduce
anyone from Qatar, because there will be the opening ceremony of World Cup.
Yeah, it's nice.
Yeah, we have 1 more hour, so yeah, maybe we should finish here and then have some time. Wait.
Okay, I think we got all the questions there, Wan Lee.
Yeah. Okay, thank you. So I think we thank you everyone. Thank you, Professor Teo and Professor Hong. Thank you for all the friends here and all the audience. Yeah. So next we can see you 2 weeks later, right?
Right. Okay, we'll be posting notices. Thanks for running the show, Wan Lee. And thanks to Ben Zhu in absentia. And we'll see you in 2 weeks.
Okay. Thank you, everyone.
Thank you.
Thank you, Dr. Hong.
Thank you, Dr. Miller.
Thank you, sir. Thanks, Professor Chan.
Pleasure.
Okay, we're off the air now. We can network if you have time. You want to say hello to the community, Ahmad? From Afghanistan.
hello.
From Afghanistan.
Yeah, this is Dr.
Hi.
Ahmed Fawad Pinzat from Afghanistan.
Oh,
Nice to meet you.
Nice to meet you. Thank you.
and Dr. Hafley. I'm sorry, I didn't pronounce that right.
Hello, everyone.
Where are you from, sir? Where are you from?
I'm living in Germany. I'm from Yemen.
That's right. We met you last broadcast, correct?
Yeah. And we have our first snow in Wolfsburg today.
Oh, okay. You're in Hamburg now?
Yeah.
Okay,
And
very
it's
good.
snow. We have like -7 centigrade.
10 degrees. Wow. In Miami, it's 70.
70, I saw almost 30. We have just -7.
Oh, boy. Wow. I don't miss those days.
No.
Hello, honey. You want to introduce yourself? You want to say hello to the international neurosurgery world, honey?
Hello, Dr. Rin.
Okay, tell us who you are and where you're at, honey. Where are you at? Where are you at? You're at the hospital, obviously, in
Yes,
Managua, right?
Yes, right now I'm working out.
You should be a prisoner of war. I can't get any information from you. Anyways, I thought it was funny. Okay, we're gonna sign up. We're gonna sign off. Okay, thanks, Juan Lee.
Okay.
Thank you.
Okay,
Bye-bye.
goodbye.
Bye-bye.
Thank